That's my biggest fear, to do this and to not have it recorded and then have to go back and just do it myself, by myself. All right. Okay, we'll leave it as it is. Okay, so good morning, everyone, and welcome to episode 12, where we're gonna do a question from a patron. So thank you, Stephanie, for suggesting this question. As I was having a chat to her this morning, I don't know whether to thank you or to sort of get my anger up, because this was a hard question, which I had to spend quite a bit of time on, but it was good. It was actually really good to look at it and think about it and actually find a solution to the answer. Now, just quickly with the breakdown of the SAQs, what we're going to do is we're going to review the examiner's reports. And then after that, we're going to do a lit review. I'm going to present the key concepts. And then we have an opportunity for you guys to ask any questions. I'll show you how I'm going to create an answer structure to this question. And then we're all going to write an answer to time. Now, this was the question that was requested. So this was the August-September 2020 question 9, which was discuss factors that influence the toxicity of local anaesthetics when used for topical anaesthesia of skin and mucosa. And I believe the pass rate was less than 10% for this question. Now, going through the examiner's reports, it was as sort of Stephanie sort of described in the email, it probably wasn't as helpful as what others examiner's reports have said. So it's more, this examiner's report probably described more in terms of why people went astray and didn't score the marks that they could have, which was attributed to the sort of the low pass rate, rather than sort of telling the candidates what the actual answer is or was. So the question had a very low pass rate, as most candidates only addressed part of the question. Common mistakes included limiting the discussion to local anesthetic systemic toxicity and not discussing other forms of toxicity resulting from metabolites, pharmacodynamic effects, drug interactions, and allergic reactions. Another common mistake was to only discuss the absorption of topical anesthetics without acknowledging other pharmacokinetic processes. Despite having a low pass rate, candidates typically wrote long answers. The long answers included topics that did not answer the question, such as details on the mechanism of action of local anesthetics, or added peripheral support to the answer, such as lengthy descriptions of the symptoms of LAST. Finally, using examples of local anesthetics that are not used for topical anesthesia did not attract any marks. In summary, candidates are encouraged to read and answer the question carefully. I think this, I always laugh at this last line, because I always think that, look, if there's always a combination of why questions score poorly. So I think sometimes it's also a factor that the questions are not phrased in a way that it's clear to candidates what they're asking. And also, you know, I think that very, very rarely is it a candidate knowledge, because I think if you ask the right questions, most of the time, the majority of candidates will be able to discuss the key concepts that are being questioned. Now, I haven't written, normally I write what will score a good pass or what will score extra marks. I haven't done so here because I agree with what Stephanie said in terms of that the exams report probably doesn't give you a key idea in terms of what you actually need to score, how to actually score a pass on this question. Now, just a summary is that the toxicity from topical local anesthetics can be due to local anesthetic systemic toxicity, agree, can be due to metabolites, can be due to pharmacodynamic effects, drug interactions, allergic reactions. But the key question that remains unanswered is, what are the factors that influence toxicity? That is the key objective of this question here, and it is specifically applied to topical local anesthetics. But this question here, I'll tell you my framework for this, okay? Now, just before we do that, this is the literature I've used for anything sort of discussing the specifics of local anesthetics. So you can find it from Miller's chapter 29 and Stolting in chapter 10, which I've attached in the Patreon page. Now, this is how I think about the factors affecting toxicity. So this is my framework. You won't find it in any textbooks. You may find sort of maybe some adaptations, but you won't find this. And so what I'm saying is feel free to adapt it and change it and evolve it in a manner which makes sense to you. Okay, so I'm just going to give you my framework, and you can change it however way you want, so that it represents a way that you can understand this question. Now, I've got toxicity here, and when I think about toxicity, the first thing I think about in terms of the factors are the drug choice. In other words, specific drugs will have specific toxicities associated, both systemic and local. So there might be general classes, and there also might be specific drugs within that classes which have specific types of toxicities that you need to discuss. So that's the first step in the thought process about toxicity. Now, after you think about which drug you've chosen, the next step I think about is what I call drug exposure across time. And what this means is that it's a function of both the concentration after a bolus, as well as the concentration following infusions and let's say frequent bolusing. Okay, so in other words, I've tried to have a description that encapsulates both potentially the acute toxicity as well as any potential chronic toxicities that may be associated with drugs. Now, you may sort of remember this term from episode 5, where I talk about the drug exposure across time, which represents the area under the curve when discussing about clearance. And if you look back at episode 5, the formula is clearance equals drug, or equals drug dose divided by the drug exposure across time. So this is really a play on that. And it also allows you to bring in other concepts in which affect the drug exposure across time. And we'll discuss that further when we discussed about applying this sort of framework to this question here. And lastly, after you've had the drug choice and the drug exposure across time, I've got patient variables, okay? And these can be things like age, gender, can also be due to any medical conditions, which can affect the interplay between the choice of the drug as well as the drug exposure, which then leads to ultimately toxicity. And many of you might be very eagle-eyed and understand that the way that I've described this essentially is 1, this is pharmaceutics. 2, this is pharmacokinetics. And 3, this is pharmacodynamics. And the way that I've described it is just another way to describe those 3 core parameters. But I think it's a lot more elegant to describe it as such, so that it actually represents the reasons why, you know, pharmaceutics, pharmacokinetics, and pharmacodynamics contribute to toxicity. In other words, that the drug choice, so which drug you decide to choose, will affect the toxicity, how this how the pharmacokinetics affects the drug exposure across time will affect toxicity, and the patient variables, okay, or pharmacodynamics will affect toxicity. So I hope that makes sense to you. This is probably one of the key slides here. Now, let's use this paradigm to answer this question here. So the first one is drug choice. And the first question is, what local anesthetics can be used topically? And so the way that I've divided it is into amides and esters. And, this is not an exhaustive list, and you can certainly, I think, choose other ones here. And but the ones I have are lignocaine and prilocaine, which is in amla cream. And then the esters that you can use are cocaine, methocaine, procaine, and oxybuprocaine. So procaine is what they use in dental. It's called novocaine. And oxybuprocaine is and methocaine. So there's also a methocaine which you can use topically for, I think the Royal Children's makes it as a formulation for IV cannulation. And it's also available in eye drops. Methocaine and oxybuprocaine are both available in eye drops. All right. And, knowing that these are the drugs that these are the local anesthetic drugs that we commonly use for topical anesthesia in both mucosal and skin membranes, it allows you to think about how some of these drugs will have general toxicities as well as specific toxicities related to them. Now, so this is the next question. What toxicities are specific to these local anesthetics? And the way that I've summarized this is that, look, all local anesthetics exhibit a dose-dependent systemic toxicity based on their CC-CNS ratio, resulting in CNS toxicity. And this answer here doesn't, I don't think it requires a description of the mechanism. So I've just briefly said that there's initially an excitatory response followed by CNS depression. Now, specifically, lignocaine's metabolite, I think it's fine just to remember it as MEGX, but if you want to know what it is, it stands for monoethyl glycine xylidide. It has also been implicated in seizures, okay? And that we also know that cocaine can also reduce your seizure threshold as well. So these are the specific toxicities related to these local anesthetics. Now, with the cardiovascular toxicity, so again, just a brief summary, it's due to the blockade of sodium channels leading to negative inotropy and arrhythmias. And the specific ones is related to cocaine, which can cause coronary vasospasms, ischemia, and dysrhythmias due to sympathetic stimulation from reuptake inhibition of noradrenaline and dopamine. Now, other ones that are specific to local anesthetics, so prilocaine. So the metabolite orthotolidine oxidizes hemoglobin to methemoglobin. And then also with regards to anaphylaxis or topical irritation, know that esters tend to have more incidence than amides, because when esters get hydrolyzed, one of their metabolites is PABA, or para-aminobenzoic acid, and this is known to be quite immunogenic. Now, for step number 2, the drug exposure across time, what factors affect this? So quite simply, the key thing is that if you increase the drug exposure across time, you are going to be increasing the risk of toxicity. And the factors that would increase this are things like the dose that you use. So increasing dose would increase the drug exposure, and also any concurrent use of systemic or regional local anesthetics, because the effects are additive. All right. Now, this is probably where a lot of candidates would spend their time discussing this question or answering this question with this. And you can see that this only forms a very small component of my answer. So the other factor that increases your drug exposure across time is the amount of systemic absorption, or what we call bioavailability. And when we talk about topical local anesthetics, we know that it really depends on the route of exposure. So you're going to get a lot more absorption with mucosal surfaces compared to the skin. And this is also based on Fick's law of diffusion, where the net transfer of drug equals the surface area divided by the thickness, multiplied by the partial pressure gradient, multiplied by the drug's solubility, divided by the square root of the molecular weight. And that would be as much as I would probably put down for this answer, because there's actually so much to talk about with regard to the other factors that influence the toxicity of topical local anesthetics. Now, other things are, there's also the increase in duration of exposure and increase in frequency of exposure. So I've just got this little snippet here. So this is from the EMLA product information. And you can see here that they tell you, all right, with EMLA cream, the amount of EMLA cream you can use for a neonate and the duration. So 1 hour, not more. And then after that, they talk about the frequency. So only one single dose should be given in any 24-hour period. Right? And you compare that to, let's say, for someone who's a little bit older, you can use up to 20 grams of the cream, not larger than 200 square meters. And the application, again, is for an hour and a maximum of 5 hours. All right. And they also talk about a maximum of 2 doses, at least 12 hours apart. Can be given to children over 3 months of age in any 24-hour period. So even with product information with regards to topical local anesthetics, they talk about the duration of exposure as well as the frequency of exposure, because these concepts will affect the risk of toxicity. Now, as you sort of realize from episode 5, when I talk about the drug exposure across time, it is related to clearance. And it's also related to your elimination rate constant. Okay, but I'm not going to bring this, I'm not going to talk about it here. I will, in fact, because it's quite complex, because then that also brings in the idea of volume of distribution as well. And I will have a slide on that to show why it's such a complex concept to bring it into the argument of toxicity. But in terms of simplicity, I think it's just nice to leave it at clearance. So with clearance of local anesthetic drugs, it's primarily through metabolism, and there's only, with renal excretion, there's only a small amount of local anesthetics that are renally excreted, but they are metabolites. Which can accumulate if there's any sort of renal dysfunction. Okay, so with clearance, and where you can get an increase in your drug exposure is that if you have decrease in metabolism, specifically through hepatic enzymes, and the determinants are going to be hepatic blood flow, which is a function of your cardiac output, and then that's also multiplied by the unbound fraction, and that's related to protein binding, and then also the intrinsic clearance as well, which is the enzyme activity. Okay, so you've got 3 things that are related to the metabolism of local anesthetics, but these can be applied to any drug. Any drug that is hepatically cleared will be dependent on the hepatic blood flow, the amount of protein binding, and the amount of enzyme activity. All right. And what you'll see is that this term here, the unbound fraction multiplied by the intrinsic clearance, can often be defined as the hepatic extraction ratio. Now, these are for amides, all right, with the hepatic enzymes. For the esterases, they are metabolized primarily by plasma esterases. The only caveat here with the local anesthetics that we've talked about is cocaine. So cocaine is also metabolized in the liver as well by hepatic carboxyl esterases. That's the only exception to this rule here. All right. Now, talking about reduction in clearance, so there's a reduction in excretion by the kidneys, and that's only relevant for lignocaine's metabolite MEGX. Okay, so for the xylidide metabolite, and that can accumulate in patients with a reduction in their renal function, and I will talk about this in the patient variable section. All right. Now I've got this slide here because this is like an inverted warning sign with a D. So in other words, this is like a V and this is a D, just to give you that warning sign about the concept about volume of distribution and how its play on toxicity can be quite complex. I think bring it in if you're confident. But I think sometimes this one is probably better to be had, in a Viva setting rather than in a short answer question setting, because of the time it takes to actually explain it. And this is the reason why. Now, when we talk about the volume of distribution for local anesthetics, what's been shown is that it's best modeled with a 2-compartment model. So they have a rapid compartment and a slow compartment. And the rapid phase is dependent on your blood flow or your cardiac output. And the slow phase is really dependent on the properties of the local anesthetic. So that would include the lipid solubility as well as the degree of protein binding as well. Now, from episode 5, we know that your elimination rate constant equals your clearance divided by your volume of distribution. And that would hopefully make sense, for clearance. So if you reduce your clearance, you reduce your elimination rate constant, which means that you increase the amount of drug in the body, or you increase your drug exposure across time. Okay. What becomes complex is the play on volume of distribution. So if there's an increase in volume of distribution from this formula here, there is a reduction in your elimination rate constant, which increases your drug exposure across time, which can potentially increase your risk of toxicity. But this is only relevant for infusion or repeated dosing. The reason why I say that is because we also know the other formula, which is the concentration at peak effect, equals your dose divided by your volume of distribution at peak effect. And therefore, this is the opposite. If you have a reduction or a smaller volume of distribution, that means you're going to be increasing that concentration, okay, at peak effect, which then also increases your risk of toxicity. And this is why it's complex, because you can see how you can get different volumes of distributions and how they can be related to your risk of toxicity. And this one here with the volume of distribution of peak effect, that's more relevant for bolus dosing. So this is why this is such an interesting concept. It's a really good concept to sort of discuss in a Viva. Quite hard to actually, I think, talk about this, I think, in a short answer question. It's possible, but yeah, there is a lot of concepts sort of involved with this line of thought. Okay. Now, the third thing is patient variables. So what factors affect this? Now, the way that I've done it, there's 2 ways you can do it. So my format, which I said before, was to think about ages, think about gender, think about medical conditions. But I think the other way to also think about it is what happens as the result of it, and what are the causes from all those 3 groups. Okay, so we're going to do it the other way. We're going to see what the end result is, and we're going to try to tie it into age and medical conditions. All right, so we've got an increased half-life of lignocaine. You have that with decreased hepatic blood flow. as well as decreased hepatic function. Now, remember that from our previous slide, so let me just go here. With regards to metabolism of hepatic enzymes, it's a function of both hepatic blood flow, your protein binding, as well as your intrinsic enzyme activity, okay? So what I've got here is that you have an increase in half-life of lignocaine with decreased hepatic blood flow, which can happen in the elderly because of decreased cardiac output. And in fact, I should probably change that to decrease cardiac output. Okay. And also cardiac failure as well. And then the second thing is decreased hepatic function. So you see that in neonates with immature hepatic enzymes, as well as patients with hepatic failure. Now you get accumulation of lignocaine's metabolite MEGX, the xylidide metabolite, and that is again due to decreased renal function. And you see that again in neonates, as well as patients with renal failure. Now you get an increase in your CNS toxicity, and that's due to acidosis and hypercarbia. And the mechanism is that you get increase in blood flow to your CNS. It promotes ion trapping, and it also decreases protein binding as well. So that's the mechanism of how acidosis increases CNS toxicity. Now, with cardiovascular toxicity, again, it is potentiated with acidosis and hypercarbia, but also hypoxia as well. And there's a potentiation of the negative chronotropic and inotropic actions from local anesthetics. So these are some medical conditions or patient variables that will affect the toxicity of the topical local anesthetics. And then after that, we've got the increased risk of methemoglobin. So that can be divided into genetic and other drug interactions which may be given to the patient. So the metabolic disorder, you don't need to remember this. It's the specific one is NADH cytochrome B5 reductase deficiency. That is the one you need to avoid in patients with, so patients who have this, you don't want to be giving them emlacrine, all right? There is another one that there's a contraindication to, so I think it's the G6 phosphatase deficiency. And that one there, it's not because of the effect of prilocaine, it's because that in those patients there, what happens is that if they do get methemoglobin and you do give them methylene blue to treat the methemoglobin, that actually makes that process worse. Okay, so you'll see on the product information sheet that that it is contraindicated in patients with G6 phosphatase deficiency. All right, and it's not because of the increased risk of MET-HB. It's more so that if you need to treat MET-HB with methylene blue, that is the problem. And then drug interactions include things like sodium nitroprusside or phenytoin, which again can increase your risk of methemoglobin. Now, I'll just sort of show you what my structure will look like. Okay. So the way that I'm going to do it is I'm going to define toxicity. So toxicity can be defined as the adverse effects of a drug, and there's multiple ways to then sort of go on to talk about that, whether they can be both systemic or local, they can be reversible or irreversible. But yeah, it's essentially just the adverse effects of a drug. And I'm also going to define what topical local anesthetics I want to talk about. After that, the factors that affect toxicity, I'm going to have drug choice, which is essentially pharmaceutics, my drug exposure across time, which is pharmacokinetics, and patient variability, which is pharmacodynamics. And within the pharmaceutics, I'll talk about the toxicity specific, so that are general to all local anesthetics, and then they're also specific to some local anesthetics. So we're talking about CNS and CVS toxicity, methemoglobin, allergic reactions with the drug exposure across time. The ones that I'll talk about are absorption and clearance. If I have time, I might add in volume of distribution, but there's a lot to cover from what I can see. And then with the patient variability, I want to be talking about, you know, the effects of age, the medical conditions, and also genetic factors as well. All right. Great. Okay. All right, you guys got your pens ready?
Mm-hmm.
All right, and let's go. So I'm going to have my definition here. I'm going to have factors that affect toxicity. 1, drug choice or pharmaceutics. 2, drug exposure across time, which is my pharmacokinetics. And 3, patient variability, which is pharmacodynamics. Right. So toxicity of the adverse effects of a drug and can be systemic or local. Topical LAs include 1, NITs, which are lidocaine and prilocaine in EMLA with lidocaine, and 2 esters such as cocaine and with drug choice. So all local anesthetics exhibit dose-dependent systemic toxicity based on the CC-CNS ratio, resulting in CNS toxicity, so excitation followed by depression. Now, lidocaine's metabolite, NEGX, also implicated in seizures, and cocaine can also reduce seizure threshold. CVS toxicity, negative anatropy, and dysrhythmias. Cocaine can induce coronary vasospasm due to increased sympathetic stimulation from reuptake, inhibition of noradrenaline and dopamine, B, pralocaine metabolite, O-tolidine can reduce HB to net HB, and esters metabolite PABA immunogenic, can cause anaphylaxis or local skin irritation. Drug exposure across time, looking at factors that increase a increasing dose or concurrent use of other local anaesthetics, increasing systemic absorption or bioavailability. That's dependent on the route of exposure. In other words, mucosal more than skin, and based on Fick's law of diffusion, where net transfer of drug equals surface area divided by thickness multiplied by the partial pressure gradient multiplied by the solubility by the molecular weight, increasing duration and or frequency of exposure, the reduction in clearance due to decrease in metabolism based on hepatic blood flow, protein binding, and intrinsic enzyme activity for amyLAs. And then also we've got plasma esterase activity for ester alase, and also decrease in excretion renally relevant for lignocaines metabolite in GX. Patient variability, so you get increase in half-life of lignocaine with decrease in hepatic blood flow in the elderly or patients with hepatic failure, decrease in enzyme activity in neonates, or sorry, that's heart failure, or patients with hepatic failure, increasing in NGX in neonates or patients with renal failure, increasing CNS, CVS, toxicity with acidosis, hypercarbia, and hypoxia, and increasing met HB with metabolic disorders or use of SNP, so metoprolol. All right, that is it. I think that's all I can write, actually. I've got 9 minutes 50. All right, that's time. All right, so this is my answer here. I've got my first page, which has my definition and the type of topical local anesthetics that I'm using. My first page, which is about drug choice or pharmaceutics. Second page, which is about drug exposure across time or pharmacokinetics. And then the third one, which is patient variability or pharmacodynamics. What I can see is that probably at the end, I've really had to summarize a lot of the stuff with the patient variability just because of timing. And then the question goes back in terms of is there anything else that I could change in terms of being able to fit what else is in there? And so look, did anyone else have anything different or approach the question differently that they want to share?
Yeah, I think this is amazing. Thank you so much. I think firstly, hanging this like unique structure of approaching toxicity on something that we already know is really, really good. So that, like you say, if you see anything about toxicity, a new question, and you're just not sure what to do, if you just take it back to the basics, amazing. And then I think like once you've studied this topic, you know about all of those weird and unique metabolites and other things that come with all the different local anesthetics. But I think the hardest thing was trying to like grab all those bits of information and put them into one one answer. So I think this is so invaluable. And I think you could see there was not sort of coming out with an approach. There's not a lot of guidance from the examiner's report. The model answers kind of felt like they just weren't quite there with what needed to be covered. So I think that's why I was like, this needs.
No, I completely agree.